Hello everyone, I am Dr. Rati. We'll see some certain important topics in blood vessels. So vasculitis. So what you mean by vasculitis is the vessel wall inflammation. So the mechanism underlying vasculitis are it can be immune mediated or a direct invasion of the vascular walls by infectious pathogens like bacteria, fungal, viral, rickettsial as well as spirochetes. So coming to the classification of vasculitis. This is a many important MCQs will be coming from this topic. So remember this diagram. Vasculitis can be whether it is large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis. So large vessel vasculitis involves granulomatous disease like Jain cell arthritis and Takayasu arthritis. And medium vessel vasculitis involves immune complex mediated like PAN as well as Kawasaki disease, which is caused by anti-endothelial cell antibodies. And small vessel vasculitis, it can be immune complex mediated or ANCA associated. So immune complex mediated can be SLE or Henoch-Colin purpura, cryoglobulin vasculitis and Goods-Patches disease. And ANCA associated can be microscopic polyangiitis, granulomatosis with polyangiitis and Shrug-Strauss syndrome. So here the important MCQ in small vessel vasculitis can be which are the small vessel vasculitis, one question, or IG associated, that is Henoch-Colin purpura, this can be another MCQ, and ANCA associated. Microscopic polyangiitis, granulomatous with polyangiitis and Shrug-Strauss syndrome. Okay, and other important question will be which are the vasculitis associated with granuloma. This can be these two like Jain cell arthritis and Takayasu arthritis along with these two, that is granulomatous with polyangiitis with nothing by Bergner disease and Shrug-Strauss syndrome. And another important which can ask in medial vessel vasculitis is Kawasaki disease. This Kawasaki disease is mainly caused by anti-endothelial cell antibodies and seen in pediatric age group less than 4. So this diagram is very important. Learn it properly. Then coming to ANCA. ANCA is nothing but anti-neutrophilic cytoplasmic antibodies. So ANCA is a heterogeneous group of antibodies directed against constituents of neutrophil, primary granules, monocyte lysozymes as well as endothelial cells. So ANCA can be of two types. One is anti-protease ANCA and anti-myeloperoxidase ANCA. This anti-protease protease 3 ANCA, it is previously called C ANCA and it causes cytoplasmic staining. This protease 3 is the neutrophilic azophilic granule which shares homogeny with numerous microbial peptides and is associated with granulomatosis with polyangiitis, that is nothing but Wegener's granulomatosis. Myeloperoxidase ANCA, it is previously called P ANCA and it is associated with perinuclear staining. Myeloperoxidase is a lysosomal granule which is involved in oxygen free radical generation and is induced by several therapeutic agents, particularly propyl thiouracil, and associated with micropolyangiitis and Shrug-Strauss syndrome. Then coming to Jain vessel arthritis. Jain cell arthritis, it usually affects the large arteries and seen in the age groups above 50 years of age. So the vessels which are commonly affected are seen in the head, like where arteries in the head, vertebra, ophthalmic as well as aorta. So the patient may comes with jaw pain, headache, blindness, fever, fatigue as well as facial pain, and temporal artery is usually taken as a biopsy for diagnosis. So for adequate biopsy we need at least 1 centimeter length. So microscopic findings seen in Jain cell arthritis are there will be intimal thickening, granulomatous inflammation, elastic lamina fragmentation and inflammatory infiltrate, macrophages along with multinucleated Jain cells. These patients usually respond well with corticosteroids. Next coming to a large vessel arthritis, that is Takayasu arthritis. This is generally seen below the age group of 50 years. That one, a previous one like Jain cell arthritis or seen above the age group of 50 years. This is below 50 years of age. So vessels involved are aortic arch and its branches, mostly subclavian artery, pulmonary artery, coronary as well as renal arteries, and the clinical features involves reduced blood pressure as well as weaker pulse in the upper extremities, ocular disturbance and neurological deficits. So microscopic finding in this patient involve there will be irregular thickening of the blood vessels and granulomatous inflammation with Jain cell and patchy medial necrosis will be seen. So next coming to PAN, that is polyarthritis nodosa, is a medial sized vessel vasculitis. It is associated with chronic hepatitis B, that is hepatitis B antigen and antibody complex can be seen in the affected vessels. So the vessels which are commonly affected are kidney, heart, liver as well as gastrointestinal tract blood vessels. However, pulmonary circulation is not commonly involved in PAN. So the patient will present with accelerating hypertension due to the involvement of the renal blood vessels and diffuse myalgia, peripheral neuritis and abdominal pain. Here the microscopic finding will be there will be a transmural inflammation, that all three layers of blood vessels will show inflammatory infiltrate along with fibrinoid necrosis and luminal thrombosis will be seen. All stages of activity from early to the late lesion will be seen in the same blood vessels or in a different blood vessels. Next is Kawasaki disease. So Kawasaki disease is acute febrile, usually self-limiting illness which involves the medium-sized blood vessels. It can also involve large size blood vessels, and the age group affected is less than 4 years of age. So this involves only pediatric age group, is the most important MCQ. And clinical features, it involves the coronary artery which results in aneurysm that rupture or thrombose, and it also causes MI in children. Conjunctival as well as oral erythema can also be seen in the affected children along with edema, cervical lymph node enlargements. So microscopic finding will be resembling the PAN, that is polyarthritis nodosa. There will be a dense transmural inflammatory infiltrate along with fibrinoid necrosis will be there. So usually this Kawasaki disease is mainly caused by anti-endothelial cell antibody, and they are treated with intravenous immunoglobulin therapy as well as aspirin. Okay, next we will see the small vessel vasculitis. First is microscopic polyangiitis. It's a necrotizing vasculitis which affects the small vessels. Here all lesions will tend to be in the same age in a given patient, and it is also called as hypersensitivity vasculitis or leukocytoclastic vasculitis. And this is found to be MPO ANCA associated, and microscopic finding will resemble PAN. However, there will be segmental fibrinoid necrosis of the media with focal transmural necrotizing lesions. Granulomatous lesions will be absent in microscopic polyangiitis. Next, coming to granulomatosis with polyangiitis, it is also called up Echner granulomatosis. It presents with three features, that is acute necrotizing granuloma of the respiratory tract and necrotizing or granulomatous vasculitis, and focal necrotizing after crescentic glomerulonephritis will also be present. Limited form of Echner disease will be restricted only to respiratory tract, and clinical features involve bilateral pneumonitis with nodules and cavitary lesions. Chronic sinusitis will be present, mucosal ulceration, renal disease, rashes, myalgia, articular involvement, and neuritis and fever will be also present. It is associated with antiprotease 3 ANCA, and microscopic finding will be there will be a geographical pattern of central necrosis will be there. Next, coming to Church-Strauss syndrome. This is a small vessel necrotizing vasculitis which is associated with asthma, allergic rhinitis, lung infiltrate and peripheral eosinophilia, and necrotizing granuloma and eosinophilic infiltrate of the vessel as well as the tissues can be also be present. It is found to be associated with MPO ANCA, and cytotoxicity is mainly caused by the myocardial eosinophilic infiltrate which may cause cardiomyopathy, and this was found to be the cause of death in this patient. Next, coming to thromboangiitis obliterans, which is also called as Butcher's disease. So it is categorized by segmental thrombosing, acute and chronic inflammation of the medium as well as small cell arteries, usually tibia as well as radial arteries. This disease is most commonly found in patients with heavy cigarette smokers, and age group is affected is below the age of 35 years of age. Here the thrombus may contain small microabscesses which are surrounded by granulomatous inflammations. Here the inflammatory infiltrates may extend into the nearby vessels and nerves. Okay, that is an important MCQ. And here the patient will present with Raynaud's phenomena, superficial nodular pruritus as well as claudication pain. Coming to Raynaud's phenomena. Raynaud's phenomena is nothing but its exaggerated vasoconstriction of the arteries and arterioles in response to cold and emotion. The restricted blood flow will induce paroxysmal pallor and even cyanosis in severe cases. The involved digits may show color change like red, white and blue, which is correlates with proximal vasodilation, central vasoconstriction and more distal cyanosis. So it is Raynaud's phenomena can be primary or secondary. Primary is generally seen in young females and secondary is seen in SLE, scleroderma, Busch's disease and even atherosclerosis. Then coming to vascular tumors. So the vascular tumors can be benign, intermediate or malignant. So benign may contain hemangioma, lymphangioma, glomus tumors and maxillary angiomatosis. Intermediate grade involves Kaposi sarcoma and hemangioendothelioma, and malignant neoplasm it involves angiosarcoma as well as hemangiopericytoma. Capillary hemangioma usually occurs in skin, subcutaneous tissue and mucous membrane as well as in visceral organs like liver, spleen and kidney. Histologically, they may composed of thin walled capillaries with scans coma. Juvenile hemangioma, it is also called as strawberry type hemangioma, seen in newborns and it can be multiple. They can grow rapidly within a few months, but usually completely regression can be seen by the age of 7. Coming to cavernous hemangioma. Cavernous hemangioma is mostly infiltrative and it involves deep structures and they do not regress spontaneously, which requires surgical intervention. These are composed of large dilated vascular channels which are separated by connective tissue stroma, and intravascular thrombosis as well as dystrophic calcification can be also be seen in this hemangioma. The syndrome associated with cavernous hemangioma is von Hippel-Lindau disease, in which many vascular hemangioma can be seen in cerebellum, brainstem, retina, pancreas as well as liver. Next, coming to pyogenic granuloma. This pyogenic granuloma is nothing but a capillary hemangioma which are present as a red pedunculated lesion on the skin, gingiva as well as oral mucosa. They develop after trauma. Pregnancy tumor, that is granuloma gravidarum, is a pyogenic granuloma that occurs in the gingiva of the pregnant woman and regress after delivery. Then next we'll see about capillary lymphangioma, that is simple lymphangioma, which is seen in head, neck as well as axillary subcutaneous tissue. Histologically, lymphangioma exhibits network of endothelial line spaces that can be distinguished from capillary channels by the absence of erythrocytes as well as lymphatic endothelial markers. Next, coming to cavernous lymphangioma, that is cystic hydromas. These are found in the neck and axilla of the children and rarely in retroperitoneum, and Turner syndrome is found to be associated with cavernous lymphangioma. These lesions are composed of dilated lymphatic space which are lined by lymphatic endothelial cells which are separated by connective tissue stroma, and they also contain lymphoid aggregates. Glomus tumors or glomangioma, these arise from modified smooth muscle cells of the glomus bodies, as well as these glomus bodies are arteriovenous structure which are involved in thermoregulations. These glomus tumors are most commonly found in the distal portion of the digit near the fingernails. Bacillary angiomatosis, it is commonly found in immunocompromised patients. These are caused by opportunistic bacilli of the Bartonella family, that is Bartonella henselae or Bartonella quintana. Kaposi sarcoma is intermediate grade neoplasm which is caused by human herpes virus 8. It is of 4 types, that is classic, endemic, transplant associated as well as AIDS associated. So, classic type is not associated with HIV. They usually present as a skin lesion like red purple skin plaques or nodules will be there involving the extremities. Endemic or African Kaposi sarcoma are seen in HIV seronegative individuals younger than 40 years of age. It may also involve lymph node as well as viscera. Transplant associated, these are seen in individual after receiving organ transplant following immune suppression. It involves the lymph nodes, mucosa as well as viscera, and cutaneous lesion may be also be absent in this patient. AIDS associated, these are generally the most common HIV related malignancy. It involves both lymph node as well as visceral. So, morphology of this Kaposi sarcoma lesion involves patches, plaque stage as well as nodular stage. So, in this photo we can see a red purple macules and plaques of the skin will be there, and this is a histological diagram of the nodular stage of Kaposi sarcoma, where we can spindle shaped cells will be there along with slit like spaces of vascular channels can be also be seen. So, coming to angiosarcoma. Angiosarcoma is a malignant endothelial tumors. The endothelial origin of the tumor can be demonstrated by the IHC staining like CD31 or von Willebrand factor. It involves skin, soft tissue, breast as well as liver. The tumor which arises from lymphatic vessel is called as lymphangiosarcoma. The risk factors associated with angiosarcoma involves radiation, prolonged insertion of foreign material, arsenic, polyvinyl chloride and thorotrust. So coming to questions, which of the following is a feature of temporal arteritis? So what do you mean by temporal arteritis? Is a large vessel arteritis. So it's a giant cell arteritis, okay, and it is also a granulomatous vasculitis. It's not a necrotizing vasculitis or leukocytoclastic vasculitis. So the answer is giant cell arteritis. Small vessel vasculitis is seen in, so both giant cell arteritis and Takayasu arteritis are large vessel vasculitis, and PAN is a medium sized vessel vasculitis. So the answer is microscopic polyangiitis. Next question. A 5-year-old child presented with perivascular IgA deposition and neutrophilic collection. There is a erythematous rash on the lower limb and non-blanching purpura. So the likely diagnosis is 5-year-old child as well as perivascular IgA deposition. So IgA deposition is seen in Henoch's colon purpura. So the answer is Henoch's colon purpura. Next question, pathogenesis of the following is granulomatous except. So granulomatous lesion is seen in large vessel arteritis. So here the large vessel arteritis is Takayasu arteritis, and in small vessel arteritis it is seen in vaginal granulomatosis and Church-Strauss syndrome, and Butcher's disease also will show granuloma. Only in microscopic polyangiitis, which is small vessel arteritis, there is no granuloma. So the answer is microscopic polyangiitis. ANCA is associated. ANCA is seen in small vessel arthritis. So here the small vessel arthritis is vaginal granulomatosis. Henoch's colon purpura is associated with IgA deposition, and Goodpasture syndrome is also seen with immune complex. Okay, so the answer is vaginous granulomatosis. Next question, which of the following is not a common cause of vasculitis in adults? So in children, which is the most common is Kawasaki disease. So the answer is Kawasaki disease. So hypersensitive vasculitis most commonly involves which vessels? It most commonly involves the post-capillary venules. Okay, so answer is post-capillary venules. A patient with respiratory symptoms, hemoptysis and glomerulonephritis, his C-ANCA level is found to be raised. So the diagnosis is, ANCA associated vasculitis are vaginous granulomatosis, Church-Strauss syndrome as well as microscopic polyangiitis. So the answer is vaginous granulomatosis. Which of the following is most likely to be present in the patient suffering from polyarthritis nodosa? So we have seen in polyarthritis nodosa is found to be associated with hepatitis B. So the answer is hepatitis B antigen. And in blood vessel we can see the hepatitis B antigen as well as antibody complex can be seen in the affected blood vessels. Next is histological abnormality seen in lung biopsy from Wegener's disease. So here the abnormality seen in Wegener. So you should know the histopathology finding in every vasculitis. Okay. So atypical lymphocytes invading blood vessels. These are not seen. Granulomatous inflammation of the blood vessels with numerous eosinophils. So numerous eosinophils as well as granulomatous inflammation is seen in Church-Strauss syndrome. Okay. So this is also ruled out. Granulomatous inflammation of the bronchi with Aspergillus species. This is wrong. The next is large serpiginous necrosis with palisading macrophages. This statement is true. Okay. Next question, all three structures, that is artery, nerve and vein, are involved in thromboangiitis obliterans. Okay, we have already studied in the previous slides. In Birch's disease, all the three nearby vein as well as artery may also be involved. Next question, histological finding associated with Birch's disease is So option granulomatous inflammation with Jane cells, fibrinoid necrosis with overlying thrombosis, focal androsomal dilation, and thrombosis with microabscess. So in Behçet's disease, we most commonly will find thrombosis with microabscess is the most common finding seen in Behçet's disease. Next question, PAN can occur in association with hypertension. Okay, so we have already studied PAN may also involve the kidney. So in kidney, there will be accelerating hypertension is the one of the clinical feature the patient may present in case of PAN. Next is pathological feature of pyogenic granuloma. So what do you mean by pyogenic granuloma? Is nothing but a capillary hemangioma. So the answer is capillary hemangioma. So CD marker of angiosarcoma is CD31 or von Willebrand-Frampton, which we have already studied in the previous slide. So the answer is CD31. Kaposi sarcoma is associated with human herpes virus 8, and common site of angiosarcoma is liver. These can be asked in MCQ also.